Good evening and welcome to the MyCP webinar. Those of you that don't know me, I'm Joyce Trost and I will be your host for this evening. I am the Vice President for Research and Quality for the Cerebral Palsy Research Network, and I'm really excited to host this evening. So tonight we have Dr. Julie Stutzbach and Dr. Mary Gannotti, who will be speaking about new research on chronic lower back pain in adults with cerebral palsy. They'll also talk about strategies to improve care through shared understanding of the nature of pain, how to communicate about pain, and the advocacy for treatment. Julie, who is the lead investigator of this research, will present findings from a study of nearly 300 adults with cerebral palsy. And we know that pain is a common issue for adults with CP. Up to 70% of adults experience pain, especially in their low back. And this was learned through our MyCP community registry. And this information is community members, such as many of you on this call, that have self-reported about their daily and long-term experiences with their life with cerebral palsy. So Julie will also talk about these findings and talk about how to turn them into actionable guidance, discuss chronic low back pain in particular and its impact on adults with cerebral palsy across all the aspects such as physical, emotional, and social dimensions, and how to identify how to overcome common barriers to effective pain care. So our agenda tonight is I'll just give kind of our standard 10-minute introduction to the work of the Cerebral Palsy Research Network before turning the slides and microphone over to our presenters. We'll have then the presentation, and that will be followed with a period of questions and answers. So the Cerebral Palsy Research Network was born out of an NIH meeting that our co-founders, Paul and Michelle, attended back in 2014. And that meeting concluded that there were several important initiatives that needed to happen to improve the state of the science and treatment for cerebral palsy. The first was the need for a national registry to capture patient characteristics, interventions, and outcomes for people with CP. And the second was the need for more comparative effectiveness research, given the multitude of interventions that exist for people with CP. So this image of yellow and green bubbles is from Dr. Iona Novak's famous stoplights paper, which was published back in 2020. And for many of these interventions, it's critical that we start to compare them within different populations to see what is the most effective for each population within the diagnosis of cerebral palsy. The third objective was to increase the study of adults, given that most people in the United States living with CP are adults, and most of the research is currently focused on children. The fourth objective was to plan basic and translational research agenda to discover new treatments and preventions. And the fifth was to grow the field of researchers working in the area of cerebral palsy. And finally, the conference summary noted that the importance of engaging families and people with cerebral palsy in this journey of research. So the CP Research Network was founded in 2015, a year later, shortly after this seminal NIH meeting, to optimize the life and health and wellness of people with cerebral palsy and their families through high quality research, education, and community programming. So pictured here is the group of 45 people that were brought together in Chicago in 2017 to then set a patient-centered research agenda. And that agenda was called Research CP. So this work was published in 2018, and it is the seminal paper that comes out of that meeting. So you can see and read our vision here, and I'll just summarize and say that We are an engaged community of stakeholders and health systems that have created a learning health network that really focuses on improving health
Thank you.
and well-being in ways that matter to people with cerebral palsy. So since the network was founded, we have made great progress in 3 pillars: education, research, and wellness. So on the education front, we launched the CP Toolkit from Diagnosis to Understanding in 2015, and it has been distributed to many hospitals and downloaded more than 6,300 people. We went on to release the Wellbeing Guide for Caregivers in 2017, which has been translated into Spanish and Portuguese, and the Dystonia Toolkit has also recently been published. We launched MyCP, which is the community on our website in 2020, and we conduct monthly webinars just like this one to engage the community. And our big announcement is that we will be releasing the adult toolkit within the next month or 2. It's with the designers right now, and this toolkit is fantastic. I've seen the previews, and it has been a labor of love by our co-founder, Michelle Schusterman, and a dedicated group of adults with cerebral palsy and clinicians who care for adults with CP. On the research front, we've launched our clinical registry in 2016, which now has over 18,000 patients in it. The community registry was launched in March of 2019 and now has nearly 3,000 people in it. And we've published our patient-centered research agenda in 2018. We then went on to publish the Dystonia research agenda in 2020. We've gone on to have significant funding, both from the NIH and then also through our strategic partnership with the CP Alliance Research Foundation, or CPARF, and then through the Pediatric Epilepsy Research Foundation. So in addition to the research, we've also launched 6 improvement initiatives, all the way through the lifespan early detection to the evaluation of pain in adults. So we are both academically focused with our work and clinically relevant. We've published 23 manuscripts. We've presented more than 60 academic presentations, and we are continuing to work at implementing and spreading this work across the network. From the wellness pillar, our website is a wealth of resources for cerebral palsy. If you haven't gone on there and just browsed, you will find all sorts of resources that will contribute to your well-being. We've partnered with the National Center for Health, Physical Activity, and Disability, where we refer adults to a well-being program called Mentor. And we're currently working with NCPAD to develop a pediatric offering as well. But now I'm just going to show you a little bit of information about our registries. So these 2 graphs begin to give you a sense of some of the scale of our clinical registry. So on the left, you can see a graph of the gross motor function classification system levels. So along the bottom shows you the different levels, and along the side shows you the percentage of patients that are in our registry. On the right, you're going to see a similar graph, but this one shows the distribution of the age of the people in our clinical registry. And just of note, I would think tonight to this population and to this group is that we have about 25% of our clinical registry that are adults. Whoops. There we go. We also have our community registry, which is information directly entered by people in the community. And by contrast, these 2 graphs are from our community registry. We see that we have GMFCS distribution on the left side, looks a little bit different than our clinical registry. And it really reflects the differences of the participants who are seeking information online versus those that are seeking out care at the hospitals and clinics. And on the right, you'll see a similar graph with age distribution on the bottom. And again, you can see a slight difference where we have much more percentage of adults that are interested in our community registry. So here's a graph or a map that shows our 35 centers in our Learning Health Network, which are spread across the United States. You can see we have lifespan centers, we have centers that are enrolling, we have centers that have already joined, and we have also centers that are preparing to collect and transport their data to us. All right, so we talked a little bit about our research strategy. We are really here to help 1,000 flowers bloom, to grow our grant funding and to support research which is meaningful to the cerebral palsy community. We've taken steps to set a patient-centered research agenda, to build infrastructure that will help advantage to researchers that are working in the area of cerebral palsy, and to balance between generating new evidence and improving outcomes through quality, and using the registry to monitor implementation of evidence-based medicine across our networks. All right, I'm going to show you a short animation that just shows you how the studies have developed for CPRN over the past years. Right, so in 2015, and this is when we were starting to develop our patient-centered research agenda. And then in 2016, we started to bring on more studies, more quality improvement that you can see is in green. The bubbles in white are research studies that are for kish color, are research studies looking at adults, and gray is across the lifespan. You can watch as the work of the Cerebral Palsy Research Network flows through our pipeline from concepts on the left all the way through to study execution and then publication on the right. And here we are now in 2025 with a very busy Cerebral Palsy Research Network. All right. So the CP Research Network really brings unique value. We collect data through the EMR process to avoid duplicate data entry for the clinicians. We link patient-reported outcome data to the clinical data. We support both hypothesis generation or research and identify practice gaps through QI, and we provide opportunity for the CP community to participate in research through the community-based research surveys. This enables us to study long-term outcomes, and we do all this with our 35 sites and our community through a Learning Health Network for CP. All right, so now we're going to move on to our presentation for tonight. Our speakers are Julie Stutzbach, and I think Mary Gannotti is on the call. I don't think she's maybe going to present tonight, but will be here to answer questions. Julie is a clinical scientist and assistant professor of physical therapy at Regis University. Her expertise is in neurorehabilitation and mixed methods research. And she's partnering with the CP Research Network and using the adult clinical registry, or the adult community registry for this work. So welcome, Julie. I will stop sharing and let you share your screen.
Thank you very much. Let me share my screen here and make sure we get, okay. Can you all see this now? Are we good? Okay. And it's not
Looks
presenter
good.
view, please? Okay, great. Sometimes I
Nope.
presented before with the notes showing, and that's really embarrassing. And so I'm just so glad that that didn't happen. This time I've learned how to use Zoom, 5 years after the pandemic. So anyways, here I am. My name is Julie. I'm a physical therapist and I'm an academic clinician type of person at Regis University here in beautiful Denver, Colorado. And I am really interested and passionate about improving care for adults with cerebral palsy as part of my clinical practice and now as part of my research agenda. And as you all have probably experienced, there is not as much research out there in the pain world in terms of adults as there is in children. So we're interested in partnering with CPRN and helping to fill that gap. And low back pain is the most prevalent location of pain for adults with CP. So why might this presentation matter to you? Why does understanding back pain matter to you? For adults with CP, you deserve better care for your low back pain than you might be getting. For caregivers, it can help you to support your loved one's comfort, mobility, and dignity. And then for clinicians, if we have any clinicians on the call, hopefully some of the results of our study could help you to find ways to improve pain outcomes for a population that's really overlooked. Okay, so I want you to meet Sam. So Sam is 52. They grew up with cerebral palsy. They were a part of our study, and the quote that I would use from them is that they felt like it was me against the world. Was kind of the worldview as they were growing up with CP. But now they say, I don't have any providers who are interested in CP, and they've developed low back pain. So they get some relief from low back pain from horseback riding, physical therapy, massage, but the medical interventions so far at least have been of little help. And so this is probably a common story, something that you may have heard before. So we wanted to hear from more voices like Sam in research to learn how to better serve people with CP. Pictured here is some experimentation with AI generated images that we did, and from a quote from a participant that says that the doctor told me your pain is just part of your CP, and the participant said, well, this is old news. This is not news to me. So maybe feeling some dismissal from providers, but we want to figure out how to do better. Some little fun factoids about pain and CP. Up to 70% of adults with CP experience chronic pain. Most commonly, it does occur in the low back. So that's the population that we focus on for our study. And they're less likely to access care for pain than adults without CP. So even though they may have a greater need for care for their pain, they're actually less likely than adults without CP to actually get care for their pain. So clearly some access issues here. So what we wanted to understand were what factors were associated with how much pain interferes with daily life, if it could be physical changes or issues with mental health, or if it could be something to do with how people are treated by their clinicians. And so we looked at both stories, so qualitative data. So for those of you, there might be some people here who are in the study, but those are when we did in-depth interviews with myself or one of my co-investigators to really get at the why of how they're feeling, what they're feeling in terms of their pain treatment experience. So that was one of the studies. But first, I'm going to present to you the study from the registry data. So this is going to be hard quantitative data, and it's going to be self-report from the survey. So this is the hard data we're going to use to help to understand what might help to what is associated with low back pain. Okay, so some results for the quantitative survey, how the body, mind, and environment might contribute to pain interference. So this was, we'd say, it's a cross-sectional study. So that means that we were just, at least for the purposes of this study, only able to look at one moment in time. So this is all survey-based, so it's all self-report, and it was all people like you in the community registry who are participating in this really long, valuable survey with a rich amount of information that is helping us to learn so much more about the lived experience of somebody with CP. So we really appreciate you, because I'm sure many of you were, as well, I know, I recognize your names, or if many of you were in this study. So, and for this, we had almost 300 adults with CP who identified as having chronic pain of greater than 3 months and low back pain. So just to note, we have more research that's going to come out of this, of the registry. Now that we have collected quite a bit of data, this was just a subset of individuals who had identified specifically having low back pain. So some characteristics of who we were looking at, generally on average, their pain intensity and pain interference were moderate. So what research shows is there's a wide variety, right? The CP is very heterogeneous, and that's true of people's pain intensity and pain levels. We had people with a wide range of age here, from 18 up to 78. One of the more interesting findings that I found is that people said that people said that their pain started on average 18 years ago. So they'd obviously been developing, they'd been dealing with pain for a long time. This actually led us to hypothesize or to guess that maybe people could develop resilience to pain for having it for a long time. Sneak preview that, and so if they had longer onset of pain, they might have less pain interference. That is not true. As you'll see in a minute, I'm giving away the results, but yeah, that was not correct as it happens. Okay, so here's this nice busy slide where it shows everything that we were looking at. So this is something called the biopsychosocial model. So traditional pain models look at tissue damage. So something like you would think about with like a cut on your wrist, right? So that's the tissue damage, and that's not really the right way to look at chronic pain. You have to consider, yes, what's going on with the body and the pain receptors and what's happening within your whole body, like with your brain and your spinal cord, is part of it, yes, but there's also the psychological aspects of it, or the mind, and then there's also the environment. And the environment, we know, can have an impact on how people experience pain. So we had all of these different potential factors that we thought might impact pain interference. One that we were particularly interested in was stigma. And we found that when we were looking at different potential variables to impact pain interference, stigma was one of them. We thought that perhaps people with higher GMFCS levels or wheelchair users might have less pain interference. That was not borne out as in our hypothesis. And like I said before, the years since, the pain onset didn't matter. It didn't seem to matter. So then we did find some evidence for change in best motor function. So if people declined in motor function, they were more likely to have pain interference. If they were not employed, they were more likely to have higher levels of pain interference. If they were less satisfied with their social roles and activities, if they had more depression, they were more likely to be at risk for having higher pain interference or anxiety. And then the other things that we thought about, like gender, age, income, and all these other ones, the animations go the wrong way. They actually did not, at least according to our analyses, look to impact pain interference directly in this particular analysis. And so what we did is something that statisticians like to do, is something called a regression model. So that's where we take all the things that we think are interesting, and then we try to pick the most important ones. And so what we found for this is that the stigma appeared to be very important, anxiety appeared to be very important, and change in best motor function since childhood appeared to be important. So these three things together of all those seem to best explain the variation, or how much variability we saw in the people who were taking the survey with pain interference. And so So what does this tell us? So stigma matters. And so why? That's a really interesting question. We're going to talk about that in a moment. We think that perhaps people who feel more stigma may be less likely to seek treatment for their pain. Also, people who have faced the stigma associated with disability, physical disability from their CP, also who perceive stigma associated with their chronic pain, may have a compounding effect on the amount of pain interference that they're experiencing. Also, anxiety was important. And so that tells us that anxiety can exacerbate pain interference. That's not exactly news. You know, there's been research out there showing that the anxiety can amplify pain, but I think it really stresses the importance of screening for anxiety because it's a modifiable risk factor for pain interference. And so if you think that you are experiencing anxiety, you can definitely talk to your doctor about it because it's treatable. And then also, unsurprisingly, functional decline, that had a significant impact on pain interference. So we know that function and pain are very closely related to each other. And then just a quick note, we did look at pain intensity separately. So pain intensity is a little bit different. It's how intense or how much you feel the pain in a given moment, not how much it interferes with your life. And there we found that being in the Hispanic or Latino ethnicity was at risk for greater pain intensity. Having a greater income was protective against pain intensity, so less income was more pain. Anxiety, again, came out as an important factor in the model, and having more satisfaction with social roles and activities could help to protect you against having higher pain levels. So these are other things that are certainly worthy of future work. Okay, so that was a lot, but I also want to talk to you about the qualitative study that we did because I think it's just really interesting. What we were looking at here. So we wanted to understand how do the body, mind, and environment contribute to the pain treatment experience. So for those of you who are in the study, you might remember we asked you a lot of questions. So there are a couple of different studies that are going to come out of this big giant data set that is your words. And so this is one of the two. So right now, what we were primarily interested in is how the different biological factors, psychological factors, and environmental factors might impact the low back pain treatment experience. So we were looking specifically when people are answering questions about their low back pain treatment experience, what that was like, and how that contributed to their pain and how much it interfered with their day-to-day life. And so what we did, so these are fun methods. We interviewed a bunch of people, about 25. We transcribed every word that they said. Then we all did something called coding. So we went through all the transcripts and said what it meant. And then we put them all together and we got all of our heads together and we tried to come up with common themes that we found, and we were able to do that. So we had a big team. It was very nice because we involved some PT students as well. So they got really interested in working with this population through participating in research, which I thought was really great. So we came up with some themes. Things that we asked people about were things like how they manage their pain, why they might have had a certain amount of pain relief in the past 24 hours, and then who they've consulted with to treat their pain, to really understand the why of what that person was doing right and what they could have done better. Okay, so when we were looking at one of our themes that came into the kind of psychological factors domain, there was that these interpersonal interactions with clinicians were really important. So I'll give you a couple of quotes for a couple of examples. Someone said, "You asked me before what the most frustrating thing is, but I'll just repeat that I feel like, given the prevalence of CP in the population, the general practitioner should be more prepared to address issues of pain in adults with CP and not just dismiss it as something that is to be expected or lived with." So this is very common to hear that people felt like their providers did not have expertise in cerebral palsy, the expertise that they were hoping for. Then another person said, "I can't stress enough. The key is having those medical professionals that understand and don't just accept the way they think it should be, and also having those individuals know their limits, like not trying to treat something that they're not able to treat." So it's a mix of having people with a lot of expertise in cerebral palsy and them not recognizing their own limitations and when they may need to collaborate with other providers. Okay. So then when we looked in the environmental domain, we had another theme, which is that there were systemic factors that impacted the treatment experience. And when we say systemic, we mean systemic more on a societal level. So I'm talking about things like insurance or access to providers, or sometimes people were even talking about the literal environment, like the weather. So that's kind of the broader scope of the environment and how much support and assistance they're getting. So this is very common to hear people talk about how they were getting kind of like top-notch care when they were a kid, and then it kind of dissipated when they were adult. So this person said, I think the worst thing about the way CP is treated right now is that I feel like there are a lot of resources when I was a child, but when I turned 18 and became an adult, providers either just don't seem very familiar with CP or do not treat it as something that would be addressed in any way. So I guess it's just like a chronic condition, I guess. Another person said, I just wish there were more options available through insurance, and insurance covered more, and not only covered more, but it went for a longer period of time. So people talked about how they would find physical therapy helpful and then not as helpful once the therapy would stop. And so the insurance would kind of take the blame for that. Okay. So then when we consider the biological factors or the body, people talked about how complicated their cerebral palsy was. So we came up with this theme, compounding complexities of cerebral palsy. And so this gentleman was talking about his experience in physical therapy. And he said, you know that you can't fix his arm until you look at his back and his legs and his hips. And it's a set of comorbidities that makes it challenging for healthcare professionals. It is certainly, it's a challenge. We didn't get the chance to interview providers for this particular study. And I'm sure some would say that there are additional challenges with the complexity of the condition. I would say that there were people in the study who identified these like rock star providers who took on that challenge and did really find helpful strategies for them. Another person said aging with a disability, and particularly aging with cerebral palsy, is like aging in dog years, because I developed arthritis starting in high school. And so I find that as I've gotten older, my spasticity gets worse, and so does my pain level. A lot of people talked about spasticity and had the relationship between their spasticity and their pain, and that getting worse with aging. Okay, so here's the more fun stuff. All right, what can we do? What is some actionable guidance for people with CP? So if you don't have low back pain, then you can use some prevention strategies. So exercise in a way that feels good. So weight-bearing exercise is really important. It's important for bone stimulation. It's important especially for your hips. But you also want to do exercise in a way that feels good. So if you're doing some kind of exercise that really hurts, you may need to change to a different kind of exercise, like changing from walking to using the pool or using a bike. I had a patient who I was treating for a while, and I brought her in to meet the physical therapy students, and they were working a lot on her walking and talking about her walking, and she was like, guys, I don't walk for fun. Like, this is not what I want to do. So find some kind of movement that feels good for you and then go with that. That same patient told me that she got on an intensive biking program and her back pain has basically gone away. So stretching and strengthening can also be helpful, and also mindfulness. So mindfulness is a technique that you've probably heard of, because it's kind of all over the literature, where you try to train yourself to live in the moment through things like meditation. It's not easy to do. I personally am not very good at it, but I think that there's a lot of value in it, and there's a lot of research to back it up. If you do have pain, don't ignore it. So talk to your provider, find out the why. Don't listen if somebody says it's just your CP. It's not just your CP. There could be a complication of your CP and the way that you move, but we still want to figure out more of the why so that you can get it properly treated. And then there's different options that are available for you. So physical therapy for low back pain is recommended as the first line of treatment. So finding the right physical therapist. Yoga can be very helpful for people with low back pain. Pilates, and then psychotherapy. Like I said before, anxiety was one of the biggest risk factors for having high pain interference. And psychotherapy is an effective way to treat anxiety. So find your people, talk to your network, talk to other people with CP around you to see if you can find who to go to. Because a lot of what the participants told us is that they were often using word of mouth to find the right PT or the right massage therapist or the right physician in order to get to the right person. And then once they found that person that they developed a trusting relationship with, that was really what helped them to manage their pain. And so don't be afraid to speak up. For clinicians, in case we have any clinicians on the call, or you could screenshot this and send it to your clinician. Promoting a therapeutic alliance between yourself and your patient is really important. So, and one way to think about this is just to listen. So the best providers are the ones that will listen to their clients and then explain after. And then to really capitalize on interprofessional communication and collaboration, not trying to take everything on yourself. Clinicians can also help you to find other clinicians. So go ahead and ask, because the clinician might know the best like massage therapist in the area or the best acupuncturist, or they can go and help you find that out for you. And then educating fellow providers. And we do need more research. So thank goodness we have CPRN here because we need to do more research on pain management strategies, and we are working on it. And then from an advocacy perspective, people really talked a lot about how they didn't feel like they had access to the services they need. This is just a Wikipedia picture of acupuncture. That was one of the examples of things that people thought were helpful, but they didn't really feel like they had access to. So improving access would be helpful. Some people don't know that insurance does cover things like acupuncture and massage, but some places will not directly take the insurance. You just submit it to your insurance afterwards. Support organizations like the American Physical Therapy Association. Reimbursement rates for physical therapists are not wonderful. And this may be part of the reason that can create a system where people don't get a lot of physical therapy. And then supporting organizations like CPRN, of course, as we're helping to advocate and get more research and education and quality improvement for people with CP. And then healthcare professional growth and training, I think, is another important area of development, is how we can train more clinicians to be able to be more competent in treating adults with and comfortable treating adults with CP. So I have these resources here. I know you probably can't click on these links. So I will, when I exit out of this thing, I'll put it in the chat so that you have them. But yeah, I'm really excited to see that toolkit soon. And then highly recommend the CPRN mentor plan as well. I put some links to some videos in there, but if you do have back or neck pain, discuss it with your physician, physical therapist before you embark on these videos. And then I don't know if we have any PTs here, but the APTA has a clinical practice guideline for low back pain that PTs can follow that should be able to help it's not specifically for adults with CP, but there's no reason why it can't help people with CP too. A lot of acknowledgements here for different people that have supported this work, my references, and thank you very much. And it looks like we have about 20 minutes left for questions. So I will stop sharing and put those resources in the chat.
Well, thank you, Julie, very much for that enlightening presentation. I see we have one question already. So PP is what I see. Go ahead.
Hi, thank you. That was a wonderful presentation and very encouraging to see that this research is being done finally. My question is that I know you had APTA there as one of the organizations for advocacy, and also that they have a clinical practice guideline for low back pain. How relevant is that to the CP population? Because our experience with physical therapists, and especially adult physical therapists, is that they practice episodic care. So they say, we'll treat you and we'll teach you the strategies, and then you go home and do it yourself. Now, a typical person can accomplish that, can do that, but people with CP, and especially when they have mobility issues and they're not able to move their muscles as typical people, they are going to need assistance. They're going and need assistance from people who are trained to do work with people who have cerebral palsy and the way their body is structured and designed or functions. So how do we address that? I mean, I know you had services on there as one of the limitation or the barriers to this care, but I feel like as if we need to educate the APTA first to train physical therapists to practice the right thing that's needed for CP population.
Yeah. So Medicare will, so in the US, Medicare will cover maintenance therapy. I'm not sure what all the models are like, and it's different in every country. But it is coverable by Medicare for a patient to come in regularly to get this maintenance therapy if there's something that a physical therapist can provide that they can't teach the patient or the caregiver to do themselves. There's that like stipulation with that they have to justify it to the insurance company by saying that the patient can't do it themselves or the caregiver can't do it for them. A strategy that yes, I like that comment. I always tell my therapist we're peeling an onion. A strategy that, you know, I take with my patients is making sure that they're like set up for success by the time they are discharged. I mean, the episodic model of care is kind of the model of care, at least in the United States, for adults of all diagnoses, for better or for worse. And so what I'll say to my patients is to give them something very specific to leave with, in addition to community referrals, so that they can have, you know, maybe a massage therapist that they're going to, or an acupuncturist, so that they're involved in some kind of like group exercise program or online support group, that there's something outside of just like a sheet of paper with like, these are the exercises that you should do every day for the rest of your life. And then also having them come back in at a later time in order to get checked in and just make sure. And sometimes that is just like a literal checkup. It's like, okay, you're doing fine, and you know, let's just keep going with what you're doing. And sometimes it's like, I need to see you for another plan of care. I need to see you for a couple times. But keeping a relationship with a clinician is, I think, really important for managing pain long term.
So what I'm hearing is that there is still resistance to continuing care for people with CP. That I'm still hearing that, yes, it's episodic care. When I think that from your research and the comments that you showed, it sounds like the people are saying that I need the physical therapy help me, but when it stopped, it didn't continue. The pain relief didn't continue. So it sounds like even that person was saying that I needed this to continue. But I guess that's going to be a philosophical difference of what the patients need and what the clinicians are practicing.
Yeah, that's why we continue to do the research, is to support other models of care too. So, all right, Karen.
Yes, hi. My question is, I'm 54, and has there been any studies on menopausal and CP? I mean, I have pain, but I don't know if the pain is from my CP or is it from menopausal in my back. I was very active. I worked all over the world, and now I'm using a walker, and I have psychotic nerve and stuff like that. I'm just wondering, what have you heard? What's the impact of menopause on people with CP?
That's a really good question, and I'm honestly not sure, especially specific to adults with CP, if there's been specific studies on menopause and CP. Mary, are you aware of any?
I know that at the University of Michigan, there are a lot of studies, gynecological studies, and there are some studies on menopause. Whether or not they tease out the differences around pain, or if it focused on the menopause symptoms, I don't know. But I know that women without have a variety of symptoms. So certainly that's something looking into more, and I can look and see if there's literature and get it to Joyce to send to the attendees.
Thank you, Mary. All right, we have a question from Anna in the chat. It says, it seems like, and Julie, maybe you can read. Can you see the chat?
Seems like options from providers are to take oral medications or do the baclofen pumps. Do you have any tips to get providers to help strengthen physically? My experience has been that providers are uninformed on how to help, so they avoid and discharge from services. So I would say that people are specialized for a reason, right? So I'm a physical therapist and I am not going to implant a baclofen pump. Well, that would be a bad idea. I don't know how to do it. So there are physicians, and would the physician know exactly how to do manual therapy on you and what exact exercises to give you to help you with your low back pain? Like, probably not. That's not within their area of expertise. So I think it really speaks to building a community and a network of clinicians that you feel like can really work for you, and that specialize in different aspects. So it's nothing against the physician that doesn't know like exactly how to stretch or strengthen, but I would highly recommend seeking out a knowledgeable and experienced physical therapist who can help you to get more specific.
Okay, great, thank you. Amber, do you want to go ahead with your question?
Yeah, so what can we do in childhood that could prevent back pain in adulthood? Or is it just inevitable because of our stereotypic movement and or scoliosis related issues? I mean, because I feel like I think there's always like how we use our body from the beginning, and then you add the aging component. So, I'm thinking there might be not as much pain as a kid or different pain as a kid. But I mean, I had pain as a kid. I just never expressed it.
Right.
And that's probably what you're finding in your research with kids. And I was praised for, getting up after I fell down and not crying. So there's also that component that was, reinforced. And I'm not going to say that's true for every kid, but that's how it was in my environment, both by, family members and everybody else too. Yeah, I'm just wondering, I think it starts way before adulthood and it needs to be addressed in childhood, or are we just not looking at it? I don't want to say correctly, that's not the right word. Just like I said, because of the stereotypic movement, is it just inevitable in some way? That's just my thoughts.
A really interesting point, Amber. And you'll hear people talk about back pain being an inevitable part of life for everybody. At some point, almost everyone gets low back pain, right? But people at CP are definitely at higher risk for developing it because of some of the reasons that you mentioned, because of the way that people move, because of the deformities that they have, because of the dystonia, spasticity. There are all these like additional risk factors that are compiled upon them. Is pain inevitable? I don't know that we can really answer that question right now. I hope not. I think that there are certainly things that, you know, can be done earlier in life to strengthen really, and to try to maintain spinal alignment to the best that we can. You know, we want to prevent it from happening, but will it happen to some people at some point? Yeah. I mean, I don't think we can completely like shut it out from happening, but I think that the prevention is a good way to think about it. And I also like that you mentioned the whole like pushing through the pain thing. So there's another aim to the study that I didn't present the results to you today, but a lot of people talked about how they've been pushing through they're pushing through pain through their whole lives, and they were so used to it, and so they didn't really ever learn how to balance that push with the rest and relaxation that they would need to actually get relief from their pain and finding a healthy balance. But that's not to say that you can't find that balance either. It's just that we, you know, need to create, and we need to help create an environment that can foster balance.
All right, thank you, Julie. There's another question in the chat. Are there any research that focuses on all the various factors of aging that affect pain and spasticity? For example, orthopedic degeneration can lead to various things like osteophytes. If someone has abnormal anatomy to begin with, how to set into play with nerve pain and spasticity?
Yeah, so make sure I'm understanding this question correctly. So for osteophytes, that's like an abnormal bone growth that can happen as a result of loading on joints, and so that can be related to abnormal movements. And yeah, I mean, I think it's just, so you're just kind of pointing to how complex the pain phenomenon is in adults with CP, that you have the like, so if some of you might be familiar with the terminology nociplastic pain, noci and neuroplastic pain, nociceptive pain, and noci, oh. I was like, second. But that there is a degree of there is some complexity. I don't actually feel like I don't have a good answer to this question, and I'm sorry.
Is Mary? Oh, Mary, you're still there.
Your hand.
Yeah, I think
But you're muted.
the answer is no, we're not there yet. I mean, we're still like, oh my goodness, people with CP have pain. Oh my goodness, it's really bad. And then trying to parse out, it's going to be very individual. I mean, and you know, the best thing for prevention is, you know, healthy bones and healthy skeletons. But it's really complex, and I think we do need to re-examine the interventions that we do in childhood. People that are in their 60s had, you know, or 70s had birthday surgeries, and that can't be good for your bones. But it is very complex, and we're not there yet.
All right, Rich, you have a question.
Thanks. I guess first, to address Amber's question, some of the other questions in the chat, something that, you know, I think would be helpful is if there's communication, you know, in your mentoring network or down to the 18-year-old who comes out of care, like, here are the graphs of what you're going to be, you know, liable to have. So, I mean, my experience, my CP is minor. So when I was in my 20s, it was, you know, whatever, I'm just going to ignore it. And then as you get older, you're like, oh my gosh, right, I really wore things out. And so I think if you had that warning, yeah, you know, I mean, is it inevitable? No, but is it too late? Yeah, because now when I go get an MRI on my lower back, here's the findings, and it sounds like that's part of the questions. You know, you've got these, you have damage, right, and it's going to be painful. you can go strengthen and that kind of thing, but you can't fix it. My question really stemmed from, so I had an upper back fusion that as a person with CP, the doctor was not really familiar with CP. And so I wasn't really warned that when I came out of it, that the spasticity and everything was just going to go to 10. And I was wondering if you could maybe speak to any experience you had with folks who do lower back fusions to fix those issues. I know it's sort of I view it as kind of the nuclear option, but again, those that I've talked to or doctors that I've talked to about it is, well, this is, you can go strengthen things, but the defects are there. So, but their familiarity with CP is so low that you're really risking an impact to your life. So for me, it was like 6 to 8 months. Started with some paralysis. Like, it's crazy. And they were like all worried about me drinking from a straw was all I was supposed to be worried about for the first 3 weeks or whatever. Like, oh, you're just gonna have to drink from a straw. You won't be able to swallow. You'll be fine. So anyway, that was kind of a long-winded approach, but I didn't know if the study touched on or if you had any experience with surgical options for lower backs.
Yeah, so sometimes surgery is warranted, and we think about surgery, especially if there are neurological issues that are coming specifically from your low back, not coming from your CP. And that can be sometimes tricky to distinguish. So people at CP are more likely to develop spinal stenosis. So that's narrowing in the spinal canal that can press on your spinal cord. And when that starts to cause actual neurological problems, especially, that's when you might want to have something like a fusion. You also have to think about it in terms of like in the pain aspect. I might be more hesitant to recommend something like that. Now, I don't know anything about you or your specific case. I definitely don't want to tell you to not get surgery. But it really does depend on the person, and you have to keep in mind too, like if you were to pull, and again, this is not necessarily true in your case, but if you were to pull just tons of people off the street, and 70% of them or something crazy like that. I'm totally saying the wrong number. Somebody please correct me what the right number is, but they would have abnormalities on their MRI of their spine, and not all of them have low back pain, right? So there tends to be a fixation thing. Something to be careful about is like if you get quote unquote like bad news on an MRI, to just think really like critically about it, like what does this mean functionally, and is this still like the cause of my pain, or is it something else? Is this actually more related to my brain and what's going on with that, and like so what we would call like neuroplastic pain. And again, I don't want to give anybody any specific advice, but I think it's important to consider all of the other factors. And like you said, like the nuclear option, right? Like if it is, then make sure that it is the nuclear option. Make sure the person who is going to do it has experience with this type of surgery with people with CP, like all the checks, like every single box.
And for some people, surgery is the only option if they have, like Julie said, stenosis. But another consideration is, with the fusion, where the fusion is going to be, and, how strong your bones are, and how much hardware they're going to put in, and if there might be stresses in other areas. But for some people, the surgery is the only option, and it prevents the neurological symptoms. In people without CP, there's a fairly decent success rate for some people that are candidates for surgery. So.
Thank you. I see we're at time. Julie and Mary, do you need to go, or can you stay on for another 5 minutes of questions?
minutes, but I will have to go.
Okay. All right. Linda, I'm going to go to you. Your last hand that's raised.
I don't have a question. I just think that you need to educate the kids that are turning 18 or whenever, even through their childhood, about the fact that keeping moving keeps you better. Because for some reason they're not getting the message. I never got the message. And I never got the message that at 20, I went to PT and they told me exercises for my back, and that was it. So it's just, we need to educate them as they're getting older.
Yes,
All of us.
absolutely. Totally agree.
All of us need to.
Yeah.
All of us need to keep moving. People don't realize that you have to keep moving or everything goes bad. So, yeah,
Thank you, Linda.
just educate. Yeah.
I see there have been quite a few questions or comments in the chat. Hopefully everybody can see those. I'm going to just highlight one last one. Mary or Julie, do you have any knowledge or experience with NeuroFit or NMES for spasticity management related to pain in patients with cerebral palsy?
I haven't used the NeuroFit, but I know that I have used electrical stimulation for strengthening. And usually when you strengthen, that doesn't increase spasticity. It can actually reduce some of the spasticity. So I would not be afraid of using strengthening to deal with spasticity. That's what I do. And if you've got to use the electrical stim, then use it.
Great. And then also want to bring it to people's attention that Mary did drop an article in the chat related to menopause in women with physical disabilities. So thank you everybody for joining tonight. Lots of questions, lots of research that still needs to be done, a lot of things that aren't answered yet. Thank you, Julie, for your presentation, and Mary for joining in on the conversation. And just know that there will be continued research and presentations of the research that are already done. Julie alluded to the fact that they're not done looking at all the information. So we will have more webinars that will give you opportunity to engage with Mary and Julie in this topic. All right. Thank you everybody for coming tonight. Appreciate you being here.